At this time, it is my esteemed pleasure to introduce you to probably one of the nicest people you're ever going to meet. Dr. Libby Stuyt was an addiction psychologist in Colorado since 1990. She was the medical director of a 90-day inpatient program in Pueblo, Colorado. She just recently retired from practice, but she didn't retire from staying busy. I can tell you that. She still does consultant work for treatment facilities. She is one of our speakers at the National Marijuana Initiative. She's in high demand and gets excellent ratings. And she also sits on the ISAC as a board member there. Her message is very simple. Follow the science. Let the data guide you. Again, this goes back to replacing the misinformation and disinformation we talked about. What she's going to talk about with us today, crimes of violence in marijuana, unintended consequences. So with that, Libby, I'll dial out. You've got the show, and I'll get out of your way.
Hey, thank you, Dale. I appreciate the invitation to talk. And just want to clear up, I am a psychiatrist, not a psychologist, just to check. My disclosure slides, yes, I don't get money from doing this, but you've already heard a great deal about the NMI and ISAC. This is the problem, as I see it. In Colorado, when we legalized medical marijuana, the highest potency was 4 to 5%, and we didn't have any concentrates. Now we have these concentrates that people are smoking with blowtorches. And in Colorado, as in now the rest of the country, we now have like an average of 20%, and you've heard, even higher in the plant. We have these concentrates. And we have absolutely no research on these concentrates, that they are safe or effective for any medical condition. However, we do have a lot of studies showing that there are problems with these. And my start into this really got from my running an inpatient treatment program for 20 years at the state hospital in Colorado. So this is a pretty phenomenal program, 90-day inpatient for co-occurring disorders. And when I first got there, I came in 1999 to make the program tobacco free, because I have spent my entire career working on tobacco. And when I first got there, only a little over half of the people were actually completing the program successfully, the 90 days. But making it tobacco free, adding a lot of complementary treatments and other treatments, we improved the outcomes to 80%. And so for many years, there were 80% of the people were successfully completing the program. However, when we opened the doors to legal adult use of marijuana in 2014, I started seeing problems that I had never seen before. Yes, I had treated marijuana as a problem for years. It was never anything that was major, and it was never anybody's primary drug. It was usually a companion drug. But I started seeing people with significant cognitive problems. And the reason was 80% of these people were being admitted as a condition of probation. So they had legal charges that got them into treatment. And we have a law in Colorado that allows people on probation to use medical marijuana if they have a doctor that recommends it. It is extremely easy to get the card. And as Eric Voth talked about, there is nothing that the doctors are really doing that follows any standard of care. And so people were coming into my program high on, quote, their medical marijuana. And they were not competent, really. The first month was kind of a waste because we were waiting for the THC to leave their system. And I started seeing people who, excuse me, had cannabis use disorder as their primary problem. I also started seeing people with the worst psychotic symptoms I've ever seen, the worst fixed delusions, all these other things that I totally attributed to high THC. So that made me start really looking into this and looking at the research. And what I found is that really there has been no study looking at smoked cannabis anyway, greater than 10% THC showing medical benefit. the National Academies of Science published their findings that there was some benefit for cannabis for some medical conditions. And they based most of it on the studies in this Whiting article. And none of the smoked cannabis preparations were greater than 10%. And most of them were on isolated cannabinoids. And there was even the study that I found that they did to see if it even worked for pain, period. And this was healthy volunteers willing to be injected in their forearm with capsaicin, which is the stuff out of hot peppers. Apparently that's pretty painful. And they found that 2% THC provided no pain benefit, whereas 4% provided some pain decrease. 8% caused increased pain or hyperalgesia. So that's actually what we see with opiates. And so this gentleman, he's a researcher, anesthesiologist who researches pain and cannabis for pain. And even he says that the THC range supported by scientific evidence for medicinal purposes is lower than 10%. He and his group went around the country and looked at the dispensaries to see what they were selling. This is Colorado data. And it's showing everything is greater than 15%. So all the products that you can purchase, especially in the medical dispensary, are things that are greater than what have been actually studied. And so, and you've heard this by several other people, I won't go into depth about this. We do have pharmaceutical grade THC in the form of dronabinol, and max dose is recommended 20 milligrams a day. In Colorado, before we actually passed this bill in 21, we had where 18-year-olds could purchase 40 grams a day if they had a medical card. And again, it was very easy to get a medical card. So we put together this little YouTube video, which I encourage people to watch because it really talks about the insanity of all this, that this is not medicine. We have these things in the medical market that people are using, and they believe that they're safe because they've been allowed to be aggressively marketed and sold as medicine. So kids especially are using vape oil, dabbing, wax, shatter, and these are all very high potency THC products, which is then causing significant problems with the adolescent. I love this researcher. She's doing some phenomenal work looking at the transgenerational effects of early cannabis exposure on the developing brain. And you can watch this webinar. This is through the ICR at CSU Pueblo. And what I heard her say is that no one should be using cannabis, no matter what the potency, unless you're 25 years of age or older and you don't ever plan to have children, because it is affecting the gametes. So it affects the eggs, the sperm, that then affect the developing brain of the offspring. And so we see many, many more pregnant women starting to use marijuana. The reasons they're citing it is because it helps with their morning sickness, but also they think it helps with their anxiety and depression and helps calm their stress. And it may help them feel better, but I don't think they're thinking about the effects on the developing brain of their offspring. And so we have studies like this. This is basically kind of early on, a very long perspective study of over 600 children. And then they were comparing the kids that were exposed to cannabis in utero to the kids who were not exposed. And at age 6, the kids were tested with IQ. And the examiners were blinded to whether they had been exposed or not. And they found, ultimately, when they broke the blind, that the kids who were exposed to cannabis had a significantly lower IQ than the kids who were not. Then we have studies like this coming out of Canada, where it shows that exposure to cannabis in utero may increase the risk of autism spectrum diagnoses. This is a very long, large study currently going on in this country called the ABCD study. So it's following thousands of children over a long period of time. And so that's prospective, but they've done cross-sectional analysis at different time points. And this was when over 11,000 kids, 655 of them exposed to cannabis prenatally, were in middle school or middle childhood. And what they found that the prenatal cannabis exposure actually increased the risk for psychopathology in those children. A more recent study, report cross-sectional of this finding in adolescents, it's persisting into adolescence. And there's a very long list of diagnoses in this study that you can look at where children are diagnosed with these things if they've been exposed to cannabis in utero. And the highest ones are conduct disorder and aggressive behavior, rule breaking. This is again Yasmin Hurd, the woman I showed earlier. This is research she is doing, looking at the cannabis receptors and looking at placenta receptors, and then other variables like hair cortisol levels, heart rate variability, immune-related gene expression in the placenta, finding that all of these are negatively affected by cannabis exposure in utero. So these kids are having much higher rates of anxiety problems and hyperactivity. So it's not just conduct disorder, but it's attention deficit disorder with hyperactivity, which people are running the risk of achieving. Then if you look at when adolescents start using, if they start with the higher potency products, these are the ones that put them at much greater risk. All adolescents are susceptible to the effects of cannabis, whatever the potency. But as you get into the higher potency, then they have a much higher risk of psychotic symptoms, depression, anxiety, and cannabis dependence. This is a very nice study that shows that perhaps cannabis is actually worse than alcohol in terms of effect on the brain and cognitive function. And so in these graphs, the blue bar are the kids that have never used cannabis, and the red bar are those kids that are using currently and have used in the past year. And so the kids that have never used cannabis do significantly better on numbers of error and working memory tasks. So using cannabis impairs working memory. And then the other thing that non-users do better on is with the number of errors in inhibitory control tasks. So this is like your prefrontal motor cortex. And the kids that are using regularly and currently have significantly worse problems with inhibitory control. And so then if you look at the other things, this is scores on perceptual reasoning. The kids that are not using do much better. And of course, this is over a lifetime of 7th grade to 10th grade. And as kids get older, they tend to do better. But cannabis makes them have significant problems. And this is why. Because when you're born with a certain number of neurons. During your childhood years, there's a significant increase in these neurons and a lot of activity is happening. And these are mostly stimulatory neurons like norepinephrine, dopamine, glutamate. During puberty, the brain is charged with determining which of these neurons are we now going to keep by myelinating, so we're going to strengthen them, and which ones are we going to get rid of? So we're going to prune because these are causing interference. And there are two chemicals or receptors in the brain responsible for this. One is the nicotinic cholinergic receptor. It's not called nicotinic because we're supposed to smoke tobacco. It just means that nicotine works on those receptors. And then the other one is the cannabinoid CB1 receptors. And it's not called cannabis because we're supposed to smoke cannabis. It's just cannabis works on that receptor. But one of the best things I believe that has come out of all of this increased interest in marijuana is our better understanding of the endocannabinoid system, which we now understand is a natural system that we were born with, and it's our mood regulation system. It's our homeostatic system. And so during puberty, these receptors are responsible for the brain determining, again, what are we keeping and what are we getting rid of? If you put an exogenous source of this drug in the brain at this point, you really don't know what you're doing. You're really messing up the fine tuning of this system. So to me, this means that the worst drugs an adolescent can use are tobacco and marijuana. One of the problems is the delta-9 THC has a much stronger binding capacity to these receptors than our own natural anandamide. So that is the chemical that we create, and that's why we have those receptors. And so these anandamide levels are typically elevated in the prefrontal cortex during late adolescence because there's a lot going on. But they are definitely reduced by escalating doses of high THC. So if you flood the system with THC, you can really disrupt this regulatory delicate process, and it might induce lasting effects on impulse control as well as cognitive and executive functioning. And we definitely see that. So this is a very long prospective study in New Zealand where they followed over 1,000 people. They picked them up at 13 before they were using any drugs. They did an IQ test. Then they repeated the IQ test at 38. And they found that the people who had never used marijuana had a pretty stable IQ over that period of time, whereas those who were using marijuana persistently had a decrease of an average of 8 points. And you might think, well, who cares? What does that mean? And I always say that, well, if you're Mensa, it probably doesn't mean anything. However, if you're on the average bell curve of the average IQ, which is 100, and you drop 8 points, you are in a significantly impaired range. This group has continued to follow these people. So this is a more recent publication of when they reached 45 years of age. And I've highlighted the stuff I think that's very interesting is in yellow. And so they're showing that the long-term cannabis users had this mean drop of IQ of 5.5 points, where the non-cannabis users didn't really have a drop at all. Long-term tobacco users had a drop, but not nearly like cannabis. And alcohol, which we consider to be more problematic usually, had even less drop. Whereas the people who were just using marijuana recreationally had a significant drop, and those who had quit still had a significant drop, meaning that it wasn't really recovering. And part of the reason for this is how these drugs, and this is all drugs, but I'm speaking primarily about marijuana right now, how they affect the hippocampus, because the hippocampus is where we put all of our new memory and learning. And in order to learn something new, you have to have a healthy, intact hippocampus. But if you are using any addictive substance chronically, you actually decrease neurogenesis in the hippocampus, and it actually shrinks. So there's MRI data showing that they're smaller. And this impairs anybody's ability to learn new things. This is one of the reasons I totally support tobacco-free treatment. And that's what I've pushed my entire career. Because if you've got somebody in treatment and they're smoking the entire time they're in treatment, you're still shrinking the hippocampus and people can't learn new things. And so a lot of people say, oh, well, the reason they need so many treatments is it's a relapsing disease. And I think that's a cop-out. I think that if we really treated people appropriately and aggressively enough where we were really helping them, then we wouldn't see all the relapse. I think people need to be able to have a clean brain in order to learn new things. But anyway, getting back to THC, because they all do this, I like to mention the way we study learning. One of the tests, the study learning, it's a very interesting way of showing how animals learn. So this is this Morris water maze test where there's this huge vat of water, and somewhere under the surface is a little block of wood. So what you do is you put the animal, a rat or a mouse, in the water, and you calculate how long does it take before it swims around until it bumps into that block of wood, and it can sit on that block of wood and say, okay, now I'm not going to die. You know that animal can learn because you have pictures all around the room that it can triangulate where that block of wood is. And so after it's been sitting on that block of wood and knows, oh, this is where it is, the next time you put it in the vat of water, it can swim right to the block of wood. And you go, oh my gosh, that's a really smart animal. Well, what they've done with all drugs, they find that if they get the animal drugged up, so they give the animal drugs for a period of time, and this includes nicotine and THC, they can't find that block of wood to save their life. They have to keep swimming around until they bump into it. However, the good thing is recovery is totally possible, because what has also been discovered is if you take the drugs away from those same animals and then put them in a situation where, it's like Rat Park, and where they have these wheels where they can run to their heart's content, within a short period of time, they can find that block of wood. Because what they discovered is that one of the best things to improve neurogenesis is voluntary exercise. And so this is why I believe treatment programs should offer exercise every single day. But again, getting back to THC, this is just a study showing that habitual use of high potency marijuana is definitely associated with gray matter loss in the hippocampus, meaning you lose neurons, especially in individuals with early psychosis, and that can cause false memories. As opposed to our own natural endocannabinoid system, which is supposed to be there to help us suppress unwanted memories or unnecessary memories, like I like this thing, where you parked your car yesterday. You don't really need to remember that. Then the problem with addiction, when you increase the potency of a drug, you increase the addictive potential. This is true for all drugs. We absolutely know this. We've seen this with cocaine. There's a lot of people in the Andes chewing coca leaves, and they don't have a problem compared to somebody who starts smoking crack cocaine. Or we've seen this with the opiates, but we are now definitely seeing this with cannabis. Because in the olden days, when I first started in this business 33 years ago, we really didn't think it was addicting. It was classed as a hallucinogen. Hallucinogens cause hallucinations, but don't have a withdrawal syndrome. Now it really basically is in class by itself, because with the higher potency THC, we are seeing a marked withdrawal syndrome. The Dutch figured this out themselves. They realized when the potency in the plant averaged 20% THC, similar to what we have, there was a lag time, but there was this increased need for treatment for cannabis use disorder. And they came out, this group came out in 2016 and said they thought THC potencies above 15% should be considered a hard drug like cocaine. And they recommended capping the potency at 15%. This is data from our country, and these are just big survey data. But I want to point out the one in 2004, 2005, that was done before we had concentrates in the marijuana market. And at that time, people were identifying nicotine as the most addictive drug we have. And I think most people would agree with that. This is the hardest drug to quit. Anybody who's worked with anyone, even with heroin addiction, say it's easier to quit heroin than nicotine. Alcohol, the drug that's used most by people, has less addiction potential. And then this one said cannabis in 2005 was less than 10%. However, a more recent survey, and this still isn't right now, this is still 2012, 2013, it was up to 30%. And I predict it's only going to get as high as nicotine, because that was what I was seeing in my treatment program, where and outpatient as well, that people are having a really hard time quitting high potency THC. just like nicotine. And you get addicted to it a lot faster. And what also is when you start using before the age of 18, you're 4 to 7 times more likely to develop an addiction to marijuana. And again, these are institutions profiting off of addiction. I just wanted to point out that tobacco in the 1960s, 60% of the population smoked. I just read somewhere that they're now saying 9% of the population use tobacco. But look, it's those people, that 9% that are spending all this money on tobacco. And we're seeing the same thing now with cannabis. So this is another study with adolescents, just looking at if they start using, which products are the ones that are most likely to make them continue to use. And so it really was showing that if people start using with the cannabis concentrates, they're much more likely to progress or continue to use than if they were just smoking a joint, that had lower THC in it. And this is the withdrawal syndrome. And this is something I was starting to see very dramatically in my treatment program because people were really, really irritable, very angry. Yeah, they definitely have anxiety. They think that marijuana is helping their anxiety, and that's why they're anxious, where they don't really realize it's withdrawal that is causing that. And then severe cravings for marijuana. And it lasts for a long time. That's a big part of the problem because it's fat soluble and it sits in the body for quite some time. And so the symptoms can last 4 to 6 weeks after cessation. And I was seeing some people with urine drug screens still positive in a controlled environment up to 6 weeks after admission. And so you could definitely see this. Then we have the problem with psychosis. And I think earlier on, you've heard a lot about this, and we definitely have seen this as a significant problem. This was like the landmark study that started the whole interest in this. This was out of the UK, where they were looking at people 18 to 65 with their first episode of psychosis. And they found the people that were using the 15% or more THC had a 3 times increased risk of psychosis. If they were using that daily, there was a 5 times increased risk. But if they were using the stuff that was less than 5%, there was no associated risk for psychosis. And I think that's why we had not really recognized this until more recently, because we used to have just the stuff that was 5% or less. This was replicated in multiple sites around Europe and one site in Brazil. And they found the exact same thing, only now it was for 10% or more. And I think this is really kind of the cutoff. This is where we should be focused a lot of our prevention efforts and our encouraging of legislators. I think there should be a cap, and the cap should be at 10%, because we have some evidence that there might be benefit for stuff less than 10%. But we're now seeing that the risks are significantly increased when you get to 10% or more. This is out of Denmark, socialized medicine, where they can control or keep track of everybody. So this is a very large population-based study of over 7 million individuals. And what they were looking at was, they said, well, if we're saying there's an increase in cannabis use disorder and schizophrenia because of increased potency, we should be seeing this. And so that's exactly what they found. So over a period of time, 1972 to 2016, there has been an increase in potency in THC, and there has been a 4-fold increase in cannabis use disorder and diagnosis of schizophrenia. All drugs of abuse have the potential to cause psychosis. We know that about methamphetamine, cocaine, alcohol. This was looking at, once you have a drug-induced psychosis, what is the likelihood of that converting into schizophrenia or bipolar disorder? And what they found was the highest conversion rate was found for cannabis-induced psychosis. This was almost 50% of these people were converting into a more permanent diagnosis. this is really kind of scary because for most drug-induced psychoses, you can recover from them. You have to stop using the drug. Sometimes you have to get stabilized on antipsychotics, but then if you don't go back to it, then you're okay. Then we have the problem with suicide. And of course, this is basically violence against oneself. This is a very large systematic review meta-analysis of 11 studies over 23,000 adolescents, showing that there is a significant increase in the odds ratios of depression, suicidal ideation, and suicide attempts for kids who are using cannabis versus those who are not. And in Colorado, marijuana is the #1 drug present in toxicology of teens who die by suicide. We have a very high rate of teen suicide in Colorado. And this institute came out and said we had the highest increase over this period of time in the country. If you look at this CDPHE data, it's just showing that when we opened the doors for legal marijuana, 2014, there has been a significant increase in the number of teens dying by suicide. We also found that there was less and less toxicology being reported. So that was part of what came out of the bill we were able to pass in 2021, where that would mandate toxicology reports. But even with the toxicology we did get, it still showed that marijuana is the #1 drug present in these toxicology reports. And then this is national. So this is the National Survey Drug Use and Health, looking at adolescents, over 73,000 of them, finding that past year marijuana use was a significant risk factor for suicidal ideation and behavior. And this study actually found no gender differences, so no differences between males and females, and there was no difference in race or ethnicity. So basically, everybody is at risk of this happening. And then this was an interesting study that, well, it's the Morbidity and Mortality Weekly Report this year. And it was looking at, during COVID, the pandemic, how there was a significant increase in overdoses. Now, this study was not reporting about cannabis at all, but it was definitely looking at suicide attempts in these young children and how it was significantly increased. So age 10 to 19 increased 30%. There was a 73% increase in 10 to 12, which is incredible. And most of these people, young people, were overdosing on things readily apparent in the home, like Tylenol, Motrin, some of the antidepressants, and Benadryl. But then if you take this data and then compare it to this report, which is also Poison Control Center reports looking at cannabis during this period of time. So these were suspected suicidal cannabis exposures during this period. And if you take these two articles together, it's a very compelling argument that cannabis does contribute to suicide. So then we also, as other people have mentioned, have this significant problem with drug-drug interactions. And of course, as Dr. Lev pointed out, a big part of this is people using blood thinners. And then I think Dr. Finn talked about using them when you're going to go to surgery. I've even heard of surgeons. I heard of a young adolescent person who was supposed to have an elective procedure done, a surgical procedure. And the surgeon refused to operate until he quit using cannabis, mainly because he was telling this young person that, we can't put you to sleep. It's really difficult to put you to sleep. It's very difficult to manage your pain. And so I think that is appropriate. And I'm hoping more and more people are starting to do that. And then finally, I'm getting into the violence, which was the whole point of all this, leading up to violence, because I think this is something that we need to be paying a lot more attention to. This is an early study. This was done back in the 1990s, again, when the THC potency was less than 5%. But this was looking at psychiatric patients. So these are people who had been psychiatrically stabilized in an inpatient setting, and then they were followed for a period of time. And they were followed to see whether they had any violent episodes. And what they found was that the persistence of cannabis use was associated with an increased risk of subsequent violence. And this was significantly more so than with alcohol or cocaine. Now, this was one that was more recent, but again with psychiatric patients. So these are people in their early psychosis. They had been stabilized, and then they were followed for a period of time. And what they did find, again, was that cannabis use disorder was the strongest risk factor for violent behavior. So 61% of the patients with violent behavior had cannabis use disorder, whereas only 23% did not have cannabis use disorder. And the onset of action, the onset of using cannabis increased the risk of violence. So the younger people started, the more likely they were to have problems with violent behavior. And they reported that they believed that this was linked to the fact that cannabis affects your prefrontal motor cortex, which then causes you to have lack of insight and a lack of ability to control impulses. This is a much more recent study. So this is a very large study called the Katie study. And the whole purpose of this study was to look at people with schizophrenia and their different antipsychotics to see which were the best antipsychotics to help them. But they did also look at violence as one of the factors that they were following. And so what they found was that persistent cannabis use predicted subsequent violence. Violence did not predict cannabis use. So these people were not, quote, self-medicating. They actually were having problems with violence because of the cannabis use. And so this group is saying that they think that if you are working with anybody in the schizophrenia population, you should definitely consider whether they are using cannabis or not, and actually look at that separate from other drug use, because that can play a significant role. So the reality is, marijuana does not cause the violence, just like the gun doesn't cause the violence. But the person using the cannabis then can have whatever is underlying their ability to suppress that come out. This is a very large meta-analysis of multiple studies of adolescents. And this is basically showing that there was a moderate association between cannabis use and physical violence, which remains significant when they adjusted for confounding factors, including socioeconomic factors and other substance use. So basically, they are saying that cannabis use in this population is a risk factor for violence. This is a more recent study looking at veterans. And so the green bar are veterans who have current cannabis use disorder. The orange are they have a lifetime history of cannabis use disorder, but not current. And then the blue bar is they've not ever had cannabis use disorder as a diagnosis. And so this is just showing that if you have current cannabis use disorder, you have significantly more difficulty managing anger, aggressive impulses or urges, and problems controlling violence in the past 30 days. And this again accounted for demographic variables, comorbid symptoms of depression and PTSD, and comorbid alcohol and substance use disorders. This is an issue in domestic violence situations. This is a more recent study that is looking at people in domestic violence situations, controlling for a lot of the things that can contribute to that, like alcohol use or antisocial personality disorder. And they actually found that marijuana use was positively and significantly associated with psychological, physical, and sexual intimate partner victim violence perpetration. And this is even after controlling for alcohol and antisocial symptoms. One of the problems with this study and problems with most studies to date is they're only asking about cannabis, yes or no. We need people to be asking questions that include all of the questions like how often, what's the route, what's the product, what's the THC potency, all those kind of things. This is a study where they actually did urine drug screens, and this is a really good support for why you should also do urine drug screens. And why this is important is they had 6 participants who had positive urine drug screens declined having used THC in the past 90 days. Now, it does stay in the body for a while, but I don't think it stays that long. And so these people were either lying or they basically forgot. And so this really does underscore why it's important to have things to support the data you're collecting. But they did find that the greater quantity and frequency of cannabis use was significantly associated with greater physical perpetration and victimization, even when controlling for age, gender, race, quantity and frequency of alcohol and stimulant use. Dr. Miller and his group published these several papers like this, where they're basically looking at people high profile in the news. So this is kind of eliminating HIPAA because these people are well-known perpetrators of severe violence, and looking at whether they used marijuana or not and what symptoms they had that go along with psychosis related to marijuana. And so I'm sure you recognize many of the names in here. Boston Marathon bombers apparently were using marijuana every day. Robert Deere, Planned Parenthood shooter, definitely was using marijuana every day. And so these are things that I think important to think about. This is data out of Texas, and I don't think, well, we don't collect this in Colorado. And I really love to hear what Dr. Laub is doing. So this is looking at child fatality cases in domestic violence neglect situations, showing that the #1 drug used by perpetrators is marijuana. And then this is data out of Arizona, also looking at child fatality cases. They were testing both the child and the adult perpetrator. And so they found that the drugs most common present in the children were opiates and marijuana. And the most common in the perpetrator were methamphetamine and marijuana. So I think people need to be collecting this kind of data. Ken Finn has already addressed this. I just want to reiterate the fact that marijuana has not helped our opiate overdose deaths at all. You know, when we legalized medical in 2000, this was, less than 5%, and this was all the overdose rates. We commercialized in 2009, and the concentrates hit the market in 2010. So basically, we had 5,000 people on the registry in 2009. In 2011, we had 119,000 people on the registry. So people flocked to get their medical cards. We legalized recreational in 2012. The doors opened in 2014. And that's basically when the overdose rates all took off. And so most of the research is showing that one of the highest contributors to opiate use disorder is using marijuana before the age of 18. And I think Dr. Finn explained that very well, of how the opiate receptors and the cannabinoid receptors are integrally related in the brain. And again, the industry likes to point out this first study that was done, published back in 2014, where they were looking at basically a Medicare population, and so it was older adults, and they were looking at the states who had legalized medical, but this was before concentrates hit the market. And they were basically showing there was a reduction in deaths. And so they came out saying this was proof that expanding cannabis laws would reverse the opiate epidemic. The next study was people that went in and did the exact same study of the first one, but expanded it to include all the new states that had now legalized medical. And now it was showing the time period when we had concentrates in the market. And they found the exact opposite. So basically, states with cannabis laws had a 23% increase in opiate overdose deaths. And this is something I think everybody needs to pay attention to, because we have had a lot of fentanyl overdose deaths. And when you have an overdose death, you never know whether it was intentional or accidental unless somebody leaves a note and it's clear. But this is showing for people that have opiate use disorder and they're on some form of MAT, like buprenorphine, methadone. If they have any use of cannabis, so it doesn't matter the frequency, they have potentially a 40% increase in the odds of endorsing suicidal ideation. So I think that, when people are using opiates and they die of an overdose, if they were using marijuana at the same time, it might have been intentional. So what can we do about this? Basically, we can just educate. That's all we're trying to do. I think we definitely need to increase treatment availability. I'm starting to think we need to have it more in jails and prisons because nobody is supporting the kind of treatment I think we need to have. I mean, the program I ran for a long time doesn't exist anymore. 90-day inpatient treatment. It was phenomenal, but it just doesn't exist. We definitely need PSAs about the risks. We need to we need stricter regulations. And as I said, we need to collect the right data. People have to be asking these questions. You have to document all of this. And then I really encourage people to do drug screens. I say don't opt out for the Colorado panel, and I'll explain that. So they closed my program at the state hospital after it had been in existence for over 30 years, which is very sad. But there was such an uproar, we were allowed to open it again in the community. So I was working with the community partner that was opening it. And I was detailing companies on who was going to do our drug screens. So this group from Florida, and she says, I have 3 panels for you. One is all the drugs of abuse. Another is all the drugs of abuse plus all the psych meds that have been tested. And then the other is all the drugs of abuse plus all the psych meds minus marijuana. I said, what is that? And she said, oh, we call that the Colorado panel because we've heard from primary care doctors in Colorado is they don't want to know that their patients are using marijuana because they don't know what to do about it. That's like insane. And then to support what Dr. Laub said, in Denver, they're doing some strange stuff. Like Denver Health has taken marijuana off of their drug screens. And when I asked somebody about that, they said, oh, it's because we just assume everybody will be using. Okay, that's a real problem. So this is enacting stricter regulations. We were successful in passing this in 21. We were able to get this warning, this handout that people are supposed to get when they purchase concentrates. The problem is they didn't put anybody in charge of monitoring that. So I'm pretty sure nobody's getting this handout because I've talked to people going to the dispensaries and they have not received a handout with the warnings. But we definitely need to be doing this. We need to be warning people. And I fought very hard to get suicide on this list, but the cannabis industry fought tooth and nail with that one. And then we were able to get, as I said, significant limits on the concentrates. So hard to believe, but people could purchase 40 grams a day, even 18-year-olds. And there was no control for looping. So people could go from one dispensary to another dispensary to another dispensary. Now we have controls for that. And 18-year-olds can only get 2 grams a day. And adults can get 8 grams a day. That's still a whopping amount of THC. So, okay, I am going to stop here and I'm happy to take any questions.
Well, luckily for you, there are some questions.
Okay.
So Megan asked one. This is a great question. For the risk to the reproductive system, the gametes, was there info on THC percentages?
Actually, no, I don't believe, I can't say for certain, but I don't think so. I think the message was any amount of THC can affect the gametes.
Okay.
And I just saw one showing that male use of cannabis can affect sperm that can then affect the genes for autism in the offspring.
Okay. This one's from Richard. Get your crystal ball out now, Libby. Here you go. How are so many youth using marijuana? Is it legal for them to use under 21 in some states? Fire away,
No.
kid.
No, I don't believe it's legal for any of them to use, except in Colorado and some states do allow 18 to 20 use medical marijuana. And of course, kids even less down to 0 can use medical marijuana if their parents agree to it. But in Colorado and in some states, 18 to 20-year-olds can get medical marijuana without parental consent or knowledge. And that is where it's such a crime. It's such a farce, because I have worked with several young people. They have no medical reason. Like I worked with somebody who, well, they said it was PTSD. I want people to know, and I didn't go into this talk, but there is absolutely no research supporting the use of marijuana for PTSD, none. But anyway, he was dabbing 30 times a day. And so basically I'm saying, did the doctor say you should dab for PTSD? And of course, the doctor didn't say that, because the doctors are not doing what they're supposed to do. They're not telling people what to use. And so before we got this law passed in Colorado, which limited the amount, it was basically a rite of passage for kids 18 to get their medical marijuana cards. So kids that are still in high school would get their 18th birthday, and then they would go get their card, and then they would purchase all this stuff and bring it back to their friends. And so I think that's how a lot of young people have gotten access to, what's not considered illegal marijuana. It's not black market marijuana. It's regular good marijuana.
Well, and I think also, to go to the point here, once you legalize it, you increase the accessibility of the product. So if more people have access to it, then some of it's going to slip down through the cracks. And when we look at all the pharmacopoeia of drugs that we've got, marijuana is still considered less hazardous than smoking and alcohol. And we've got great data over the last decades that show the deleterious effects that alcohol and tobacco have had. And yet here comes marijuana, almost 60% lower in terms of perception of risk. Let's see, what else we got here? While I'm reading through this, Libby, would you give the folks your email address again?
Yeah, I'll type it in here.
There you go. Okay, here's from Julie, $1 million question. How can we get states to collect the toxicology data from violent criminal offenders and perpetrators?
Oh, well, somehow that needs to be mandated. I agree with that completely. I was just hearing about this case you guys have in California right now, where this audiologist stabbed her boyfriend 100 times and killed him, and stabbed the dog, and the expert psychiatrist opined that she was under the influence of cannabis and had cannabis-induced psychosis. I think all violent crimes should have toxicology to include marijuana. And I think it should be both the perpetrator and the victim, I think.
Okay. This is from Kathleen. Are you aware of any studies that have compared today's marijuana and SSRIs and violence?
Well, no, I'd have to say I have not seen any studies that actually did that. That would be an interesting thing to look into.
Okay.
But I'll look into it and see.
Okay, excellent. And then Kelly McCormick, she writes here, could the summit provide a fact sheet for this data to make the information easy for prevention providers to share with the public? Kelly, great idea. We'll have to give you credit for that one. There's no royalties involved, so don't get your hopes up. But Libby, then in the 2.5 minutes we got left, what would you like to close with?
Well, I think this summit is so important because I think everybody that's on here has got some really important information for people to know. And it's still kind of blows my mind how people don't know this. And so I continue to give these talks and people are saying, why didn't we know this? And this thing with violence, Alex Berenson wrote this book a long time ago that, what to tell your children. I encourage people to read that book because, his introduction, he explains why he wrote the book. And he said, basically, he was talking with his wife, who's a psychiatrist who works in the forensic division, saying, he couldn't understand why people were doing such and such, whatever violence they were doing. And her comment was, well, I'm sure they're using marijuana. And he goes, oh, that can't be true. Yeah. And so she kind of challenged him to look into all that. And that's exactly what I have been seeing. And that's, I did a lot of substance abuse evaluations on the forensic division at the state hospital in Colorado. And this also got me very concerned because, of course, I'm talking to them way after their crime. So they've been in the hospital for a while. They're under not guilty by reason of insanity or there for competency restoration. And I would get the history that they were actually using the high potency THC products at the time of their crime, and it was not in the medical record at all. Yes, there was the question, do you use marijuana, yes or no? So there was nobody investigating what kind of marijuana it was, what the potency was, the frequency or anything like that. And of course, nobody was getting urine drug screens because when they're arrested for a crime, they usually go to jail first. Then they determine that they need to be at the state hospital. And then they go there maybe 6 months later. So they never got a drug screen in jail. They never got a drug screen in the state hospital. And so this is something that's been totally missed. So I'm encouraging people to really think about this, that, if you're working in a psychiatric situation or a forensic situation or in the jail, that people need to be asking these questions and then getting drug screened.